Hello everybody, welcome to qrsTV. Today I want to share a cool ECG with you from a 3-year-old female spayed Labrador. So here I have a multi-lead ECG. From top to bottom we have leads 1, 2, 3, AVR, AVF, and V3, one of the chest leads. So let's recall, what are the questions we need to ask ourselves? Here's our list of questions. We're going to go through these, albeit a little bit out of order today, but I'll start with the first two, heart rate and rhythm. And as I could appreciate on physical exam and on my ECG here, when I do an instantaneous heart rate, I get a really wide variation, all the way from about 30 beats per minute, so quite slow, up to about 150 beats per minute, more on the fast side. And similarly, I think we can appreciate right away that the rhythm is very irregular, as the heart rate would suggest. So that frames for me, I have to be thinking about bradyarrhythmias and maybe even something on the tachycardic side as well. How about my next questions? I'm going to tackle P waves, QRS complexes, and association thereof together. So first of all, are there P waves for every QRS complex? Well, if I circle this sequence of 5 beats on the left, I can see that the first 2 beats don't have P waves in front of them, whereas the next 3 do, albeit at different distances, and we'll come back to that point. So not every QRS complex has a P wave. So to me, that's implying that not all of these may be driven by the sinus node or by a supraventricular rhythm. Next question being, is there a QRS for every P? And I think we can easily see that that is no as well. So I've circled a sequence of P waves towards the right-hand side, none of which have a QRS that follows. So by definition, I know I'm dealing with a degree of AV block, at least for a section of this ECG. And then is the PR interval constant? Well, here I have to focus on the areas where there is a QRS and looking at the P in front. Do I think those intervals are constant? And I can quite confidently say no. When I look at the PR intervals that I've circled, there's a huge variability here, all the way from very short or tight PR intervals to ones that are quite long. All to say, within a range that I don't think these activities are associated. I think there's AV dissociation, and this was a theme we had talked about in a previous episode. So AV dissociation gets me thinking again that, we might have independent atrial and ventricular activity going on here. And for the slower section of this ECG towards the right, if you need a bit more convincing as to whether the P's and QRSs are dissociated, because we only have 2 heartbeats there where the rate is slower, I'm going to show you page 2, so the very next page on this same dog. Here's a longer section of, again, very slow heart rate, far less than 30 beats per minute to begin. And if I focus on the PR intervals here, once again, I'm very convinced that we have very, very short and very, very long PR intervals, all to say, again, confirms my conclusion of AV dissociation. So what about the next question, are the P waves all the same? Yes, I think they are. And furthermore, they're positive in lead 2, where I've circled here. The heart rate of those P waves, so the instantaneous rate or the atrial rate of those P waves is about 150 beats per minute. And so, it's conceivable that they could still be sinus in origin, but clearly, based on everything we've said leading up to this, this is not a sinus-driven rhythm. How about the QRS complexes? Are they all the same? My answer to that is more or less yes. There is a little bit of variability, but in large part, they look pretty similar to each other within a lead. But do they look normal? I'm going to say not quite. They are wide. And the way I know that is that these QRS complexes are wider than 2 very, very small boxes wide. 2 small boxes is 80 milliseconds, and even that's too wide. QRS complexes in a dog shouldn't be wider than 60 to 70 milliseconds, which at this paper speed of 25 would be about 1.5 of those tiny boxes. And I think these are practically 3 wide. So definitely wide. And I would say bizarre. They have a morphology that is not quite what we expect with a normally conducted heartbeat. And so when I think of wide and bizarre, I think of either ventricular in origin or at least taking an abnormal pathway through the ventricles, so an intraventricular conduction disturbance. So where does that leave us? We've said a lot of things about this ECG. Where does that leave us with our final rhythm diagnosis? I am going to attack that in 2 parts. So first, the slower section towards the right. We said there's AV block. We said that we believe there's AV dissociation. And so that to me fits with a 3rd degree AV block or complete AV block, meaning no communication whatsoever between atria and ventricles. And again, refreshing our memory with page 2, similarly, this section of the rhythm fits with that diagnosis as well, 3rd degree AV block. But it's 3rd degree AV block with something else as well, because the left-hand side of the page has a heart rate that is faster than we would expect with 3rd degree AV block in the dog. 3rd degree AV block produces a ventricular escape rate typically that wouldn't exceed about 60 beats per minute in a dog, whereas we have heart rates that are clearly faster than that towards the left. So for that section, again, because these complexes look wide, bizarre, and they show AV dissociation, so I don't think they're driven from the supraventricular foci or from the sinus node. I'm going to call this 3rd degree AV block with ventricular tachycardia. And arguably, another term that might be used here is accelerated idioventricular rhythm. Why am I sharing these 2 terms? Well, they both refer to an abnormal ventricular rhythm that has sort of taken control from the sinus node, albeit sometimes we use the term accelerated idioventricular rhythm when the heart rate is sort of less than 180 beats per minute, but faster than we would expect an escape rate to be of 60. So again, towards the left, we're somewhere in the 100 to 150 range. So that would be a reasonable term to use here as well. But all to say, it's abnormal ventricular activity, whereas during the 3rd degree AV block, the escape foci is rescuing the heart, if you will, from asystole. So final diagnosis, 3rd degree AV block with a abnormal ventricular rhythm, using the terms either ventricular tachycardia or accelerated idioventricular rhythm. And I suspect for this dog who's having collapse episodes, it's probably these wide fluctuations in heart rate, and particularly the fluctuation to a very slow heart rate that is probably responsible for this dog's collapse. And with this sort of collection of rhythm disturbances, I'd start to think about primary myocardial disease of some sort, and certainly further workup would be indicated. Hope you learned something here today, and we'll see you next time. Thanks.